dear colleagues, extremely happy to hear and see all of you remotely. And although it's already pretty late, we are discussing very serious things related to the use of information technologies. And I'm very pleased because we are talking about clinical pharmacology, the science that studies the effects of drugs on the organism. And it's a bridge that links science and practice. And this is what we need to know. Without it, clinical pharmacology has no basis. We need link to the real medicine. In information technologies, there are particular algorithms of introducing the data, interpretation of the data, analysis, and the use. And it is important to what extent and how we can interpret the data that we're getting. That's very serious, and from the quality of the incoming data and quality of information depends what we get at the end. And here is another question. Can we always trust artificial intelligence? To what extent we need let's say, disclosure that we cannot, let's say, fully interpret the recommendation? What to do with the cases that the patient may not allow using particular categories of data, let's say family, and how to balance confidentiality, efficacy, and safety. Also, there are many other things which are difficult to assess in the real clinical practice, even without the computer. When there is some artificial intelligence, then this data should be presented very precisely. So the collection and the interpretation of the data matters a lot at the first level. For the stimulation of using technologies of artificial intelligence, there are specific mechanisms of adaptation and regulation, and this is interaction with artificial intelligence, and these are some norms which is in the National Strategy of Artificial Intelligence Development up to 2030. Well, definitely there are some standards that we are using, and they also exist in the artificial intelligence for the healthcare. So this is the standard 3471, artificial intelligence in the healthcare. These are national standards that are called to regulate these key aspects, challenges that we are discussing now. And the key objective here is to identify methodology, technical and clinical tests and trials of artificial intelligence. At the same time, things which we see in the real practice, everything starts with clinical trials. How they are performed, how the information is collected, what we need to pay attention to when we look at the real clinical practice. So always in the prognosis of this data, we need to talk about the clinical trials with evidence-based data. So here we have multiple interesting questions related to the ethics and ethics of the studies, and something which is related to the AI. And we made some steps. Back in 2020, the committee was established in the Russian Federation, and here we invited leading specialists, famous colleagues, leaders in information technologies, and we have to say that the chair of the committee is a specialist in this area, so one of the leading specialists in the academy, Dr. Kuleshov, and this is Institute of Science and Technology. Ethics by itself is a universal, and it may assess multiple ethical components of the studies, universal mechanisms that can be used in clinical trials and also in the ethics of artificial intelligence. And this is how science should serve to the rights and freedoms of the individual. But at the same time, today, artificial intelligence is a challenge. It's a particular challenge to the freedom of intelligence, and to any of us, it is very clear that this is at the same time the supporter and the competitor. We can interpret it very differently, and not everyone trusts them. According to data of UNESCO, 72% of residents of US Germany, Australia, UK, and Canada don't trust AI, and 65% from 26 countries believe that ethical frames, it's a key thing for the trust of AI. So it's important to know what is the correct way of using artificial intelligence. And one of the countries that best trusts artificial intelligence is Russian Federation. So we do trust digital technologies. And the key one is the Code of Ethics for Artificial Intelligence, that international forum that called that beginning of trust. And in this context, the Code of Artificial Intelligence was signed. This is self-regulation, soft power, and this is agreement between artificial intelligence and human beings. And this is important for all stages of studies of drug treatments, especially for the studies of the real clinical practice, where we don't see this clear borderline between the practice and the start of particular study or assessment. That means how the patient or how the doctor identify that borderline which is related to the assessment of particular technologies. And specifically when we talk about the studies or when we talk about the real clinical practice. At the same time, when we talk about establishing of and design of new treatments and multiple treatments related to the evidence-based level were already established at very early stages, as you saw the theory. So we said we saw preclinical studies and clinical studies, etc. And only then we can see some evidence-based level and clinical guidelines. But you know probably that the guidelines are changing and the level of evidence is changing, and the life is continuously changing the situation. And also there is a position of repositioning when one drug could be used for very different purposes. And actually the search of new drugs or repositioning, well, sometimes it gives you the information from the typical clinical practice when the accidental findings could be the reason to establish particular projects and then artificial intelligence programs. But at any stages, we can use international technologies that provide a very good assessment of the events and also actively used by the patient itself. These mobile technologies today allow us to collect huge amounts of data, mainly in the cases where it's not easy to collect, when there is some distance. And this is not only pandemia, this is also the case where there is not very clear presentation of the calls, and in the real practice you can collect additional information. So currently very many mobile technologies that are used, they don't have, so they're not always fully available, and there are programs that require all permits which exist in the AR. So the development of mobile technology is very relevant for the country, and this is somehow allows us to combine all the efforts, some mobile systems and services and data processing and representation of the results. Well, we even have this modern definition, so-called mobile health, and sometimes they talk about the mobile studies. But speaking about the mobile health, well, the general title of the project, using of the mobile devices of the diagnosis, informing and motivation of the patients, and definitely smartphones, tablets, and modules allow to do remotely blood tests and ultrasound that facilitates the resolution of particular issues. But this mobile health, and these are mobile studies, which are of particular danger, let's say, particular danger, even for the patients themselves, because some of them do not trust that, especially elderly people. Some of them are quite tired. They have not attentive or formal attitude to that. So it's important that sociologists, psychologists started diving deep into this topic related to the mobile health, because it is not only the issue of how to assess, but also how it influences the treatment. Well, a lot was done at different stages of data collection and data interpretation, different steps of the lifetime of the treatment. But today we're speaking about with a real clinical practice, with a mature option. So I collected data in different resources. Well, we see here some advantages and disadvantages. For example, this is resource, so this is laboratory elements, so very good base. So we have some apps for mobile phones. They could be used by clinicians, by all the specialists. And this is not only assessment of the clinical practice, but this is also option to identify particular diagnostic tools. The other one, Algom, well, Russified and very convenient service. So guidelines are here, and there is a short line for the treatment, and using intellectual function provides very fast access and a calculator. Besides, there is another program, Social Medical. So this is Skolkova, and here there are some doctors and researchers that participated in the design, multiple options, very useful. Then VBMet. So this is AI system registered as a medical device. So automatic detection of diseases, sticking to clinical guidelines, and also reduce time for the interpretation of the medical data. So that means multi-level audience, pharmaceutical companies, healthcare professionals, GPs, and specialists. There are some other software, and Sberbank is actively working here. So there could be diagnostic tools, simple solutions providing care in the sorting out of data, then CheckMate, very simple interface. Again, they look at drug-drug interactions. Also Tiberius, but there is some specificity here because there is different option to interpret the drug-drug interaction depending on the version. Also, it shows the standards of the diagnosis and many others. Well, there are directions that, let's say, are priority for Russia that you can interpret in the different areas. So let me provide you some examples related to our studies here. For example, this is how to assess generics in the real practice. So it can be done at the stage of design and also in the process of clinical use. And unfortunately, we don't have the standardized common document, let's say one source where we can assess the efficacy and sufficient efficacy of generics. So all registered treatments should be effective and safe as they were studied in the clinical trials, either equivalent study or therapeutical equivalent study. But at the same time, there are some, let's say, vulnerabilities here related to treatments with high variability. And the point here is that based on meta-analysis and the results of bioequivalence studies and this data for the volunteers, you see 31,000 data from genetics and volunteers, it has been shown that there is a difference of 20% from the original treatments. Let's say, residual concentrations of antibacterial treatments, and it may lead to the development of resistance, etc. And this is so-called simulational model of therapeutic efficacy assessment. If there are some discrepancies, some gaps that may appear not quite convincing for some treatments, especially with a very narrow therapeutic range. And there are lists of such treatments. For example, there are lists in different countries. It could be warfarin, digoxin, carbamazepine, valproic acid, but also others, clindamycin, cyclosporin, and DHT, methotrexate, etc. And the point here is that truly here we can understand that if we deal with that therapeutic range where the difference between the therapeutic concentration is not convincing, then we can get not sufficient effect and very different adverse events. That is why this algorithm of decision-making was offered, where we recruit patients depending on the scoring system, and then we select decision. And depending on this data, we can forecast the non-equivalence of the results, so less informative results, and in order to make them informative, we need to have additional clinical trial data. Also, there is another interesting question. And what if there is adverse event? How to interpret it? So today we see very many drugs in the market, and to us it is extremely important. But at the same time, what is important is to assess all the adverse events that are happening in the real practice. So it's important for the authorization holder in order to have correct support to assess the efficacy and the safety of the drug. In the increased burden of the medicinal employees, HCPs, it was clear in pandemic, and well, the number of reports was low at a certain extent. So it did not depend on the fact that there were fewer messages. All the drugs were quite safe, and there was not enough time, and there is still not enough time. So that's important moment for the collection of information about adverse events. So here we are offering the software. So this is reporting, adverse event reporting, connecting to the local call center, where via email or the phone call, you can present all the data that goes to the database. Then it's integrated with the Ministry of Health. And this is how we can contact directly. And then later, this data already sent to the Росздравнадзор.
Практическую готовую информацию. То есть благодаря использованию технологий, мобильных технологий, интернета, даже пациент.
So these are mobile technologies, internet, and then even patient could register adverse event, and then it would be properly analyzed from the position of evidence base. Another important thing, how to increase efficacy and safety.
Которые есть при опросе пациентов. И, конечно же, есть популяционный подход.
So there are some populational approaches, personalized approaches, and differences in efficacy.
Здесь важно оценивать и последствия от эпидемии, что многие препараты.
So it's important to assess the consequences of pandemic, because very many drugs had fast-track registration. And we need to assess how they're working currently. And actually, calculus is helping. And this is data of Professor Zhukova, and also a number of doctorate theses. And these are prototypes of these apps, and this is how you can assess the efficacy of treatment and the scheme of treatment. For that,
которые позволяют упорядочить клиническую эффективность от большего значения к меньшему и распределение в результате получаемых лекарственных препаратов по уровню их клинической эффективности.
So that's level of clinical efficacy. And this is set by the users, low, middle, and high. It allows to get very clear graphic designs, distribution of clinical efficacy with a visual comparative analysis. That means to bring and to provide this data.
Более достоверный результат, числовую формулу и с доверительным интервалом клинической эффективности. Особенность программы – возможность сопоставления объема выборки при одинаковых средних
значениях. And this is comparison of samplings with the same medial and some number of outcomes. And this is how you can assess the reliability if you need to change the number of analyzed patients. So this is one of the elements that requires and method allows to assess this criteria. The number of positive outcomes, negative outcomes, the average cost price versus chemotherapy. And this is match code 15.
Особенность прототипа приложения в том, что возможно сопоставление объема выборки при одинаковых средних значениях, что также
in the average median data, it allows to assess the reliability of the analysis.
Методики хороши для того, чтобы оценить действенность, эффективность лекарственных препаратов. Но как управлять факторами риска, которые влияют в результате на результат?
But how to manage the risk factors? how we can bring it to the results, and how to make closer the efficacy and safety, the good clinical practice, and evidence-based medicine. So here we wanted to offer the software for the risk factor management, providing cardiological care. So this is the order of the hospitalizations, and very significant for the cardiological care. And here they try to use this mechanism for the dispensarization. So we selected the analysis of factors influencing the results, objective response, patient, doctors, medicine organization, etc. The model of automatized monitoring and the risks of cardiological care. And this is the quality and the results of the cardiological care. So this is doctor, the nurse, the experts. The collection of data, consolidation of data, and graphic analysis, factors and manageable correction here. But besides, although we have different options of artificial intelligence, we have particular risks and threats which associate the implementation of digital into life. So these are risks related to the artificial intelligence code. There is some discrimination here. There is some loss of privacy. There is some loss of control over specific studies, people, whatever, over the artificial intelligence, that this is not directly related to the doctor or to some other processes related to the artificial intelligence. This is harm, and this is a mistake of the algorithm. So one thing is when the doctor is making a mistake, and the other thing is that he's carrying the responsibility. But actually here, artificial intelligence is not always, may appear to be the correct one. To reduce the level of mistakes, it's more important task than simply train the doctor, because the mistake could appear to be fatal. There are many risk factors that can happen in the data interpretation in the real clinical practice.
Большой риск представляет применение искусственного интеллекта в неприемлемых целях. Один из этапов сотрудничества в нашем университете стало подписание.
And here there is a signing of the cooperation between the Medical University and Sberbank to establish the Center of Digital Competences to train medicinal staff, medical technologists. And this is one of the main models, is to implement electronic prescription to the territory of the region and some nearby territories, which allows to implement and test and administer the treatments, and then to assess the efficacy of the use of this method in the real clinical practice. I invite all of you to our next forum, and later on you will get detailed information. We call it digital leadership, and together with Sberbank, we are happy to carry it out in Yaroslavl. We will have both online and offline formats. So a bit later on, I will send you the full information, and we will be happy to welcome you